Welcome to the deep dive. Today, we are plunging into some incredibly important territory, really, deeply human and, yes, pretty complex stuff. The ethics of modern medicine, how the story of death is changing in our society, and the vital world of palliative and end-of-life care.
Mhm.
We're using the source material you've shared, these key excerpts from professional medical texts, to really dig in deep.
That's right. And our goal here, it isn't just a surface skim.
Mm.
We want to go deep, really explore all the concepts, the details in these sources to build, well, a comprehensive understanding, much like the professionals who actually work in this field.
Exactly. Think of it like aiming for mastery of the why and the how behind these crucial areas of care.
hmm
So what can you expect today? We'll navigate the evolution of medical practice, how technology changes the doctor's role, it's huge, and the significant shifts we've seen in, how and where people die.
Yeah, and we'll explore the core principles, the practicalities of palliative care, tackle those crucial, sometimes really difficult conversations around planning for the end of life.
Definitely. We'll look at how we manage symptoms to ensure comfort and really grapple with the complex ethical and legal considerations that surround death today.
Okay, so let's unpack this. Maybe we start by looking at how medicine itself is evolving and the ethical challenges that physicians are facing now.
Yeah, the doctor's role is just, it's so much bigger than it used to be, isn't it? With these incredibly complex technologies, they're not just using them, they need to really understand the research evidence behind them.
Right, and explain it clearly.
Explain it clearly, correct misunderstandings, which must happen all the time, facilitate shared decision-making with patients.
And advocate, too. Advocate for fair access to these treatments and even, get involved in public discussions about resource allocation, affordability, big picture stuff.
It really is.
Now, what's fascinating here is the clear line the source of material draws between therapies that are, let's say, approved and those that are unproven. Approved therapies, things like certain stem cell transplants, SAR-T cell therapy,
Right.
some gene therapies for specific inherited diseases, they have solid evidence.
Right. They've been through the process.
Exactly.
Yeah.
But then you have these claims for, well, therapies
Mhm.
using stem cells or gene modification for conditions where there's just no evidence they actually work.
And the sources are clear, these aren't just ineffective.
No, they pose serious health risks and financial risks too, often huge ones, without any proven benefit.
So a key responsibility for physicians is helping patients see that difference.
Understand the distinction, and if it's appropriate, guide them towards, properly designed clinical trials instead.
Right. Speaking of trials, what about emerging technologies like CRISPR?
Yeah, CRISPR-Cas9, the source calls it promising for somatic cell editing. That means editing cells in the body, potentially to treat diseases like blood disorders, HIV, maybe certain cancers or hereditary blindness.
Okay, somatic editing, but then there's the other kind.
Right. And here's where it gets really ethically charged, and the source is very firm on this. Germline gene editing. That's the kind that would change the fundamental genetic makeup passed down to future generations.
Oh, wow.
Yeah. And that is not permitted in U.S. clinical trials or practice. The ethical questions are just too profound at this stage.
Understood. Okay, what about AI? Artificial intelligence, machine learning, that's everywhere now.
It really is. So AI, basically computers doing tasks that normally need human intelligence.
Mhm.
And machine learning, or ML, is a type of AI that learns and improves automatically from data.
And we're already seeing it in medicine.
Oh yeah. Clinical applications include things like helping diagnose conditions from images, maybe reading a radiology scan or a retinal photo or skin images. Also predicting risks, like who might have complications after surgery or who's likely to be readmitted to hospital.
But there are risks there too, right? The source mentions.
Big risks, especially bias. If the data used to train the AI doesn't properly represent everyone's underrepresented groups, the algorithm can end up being biased.
Which could lead to worse care for some people.
Exactly. And sometimes they might predict things that aren't actually clinically meaningful, causing unnecessary worry or tests.
So how do we address that?
Well, the source stresses they need rigorous testing. Just like new drugs, really. Assess them in well-designed randomized controlled trials, looking at actual clinical outcomes that matter to patients.
And it's not just the developers, right? Institutions have a role.
Absolutely. If a hospital or clinic uses these AI tools, they need to make sure the algorithms are validated, unbiased, and they should even check how well they work in their own specific setting with their patients.
So the bottom line, ethically speaking, through all this new tech,
The core principle, as outlined in the material, is for physicians to stay informed constantly about the evidence, about the ethical challenges, and always always prioritize the patient's best interests and their preferences. That has to be the anchor.
Makes sense. Okay, shifting gears a bit, medicine is global. What about international considerations?
Right. International research, for instance. That brings challenges because you're dealing with different societal norms, different laws, different cultural views on health and illness.
So researchers need to be aware of.
Things like the Declaration of Helsinki, CIMS guidelines, good clinical practice, but maybe even more importantly, the source emphasizes partnering with local researchers and communities, respectfully, collaboratively.
And what about doctors or trainees going abroad for clinical experience?
Valuable experience, no doubt, but it can create dilemmas. You encounter different beliefs, different expectations about healthcare, different standards of care, resource limitations, different norms about, say, disclosing information.
Yeah, I can see that, like maybe being asked to do things beyond your expertise.
Exactly, or dealing with donated supplies that aren't appropriate for the setting. The key is preparation.
Yeah.
The source says people are going to need to be well prepared, get training, have mentorship, learn about the local practices and culture.
And be humble.
Be humble about their own limits, definitely. Collaborate with local professionals and the leaders sending them. They have a responsibility to ensure that training ethical, cultural, plus mentoring, backup, and even debriefing afterwards is all in place.
So wrapping up the ethics section, the main takeaway seems to be that ethical issues are just part of medicine.
They're common. Foreseeable sometimes, sometimes novel, sometimes totally unexpected.
And the way to handle them isn't to hope they won't happen, but to be prepared, informed, thoughtful, and use the resources available.
Precisely.
Okay, let's pivot now. Let's talk about the epidemiology of death, how and where people are dying, and the costs associated with that.
Right. Looking at the U.S. data for 2019, the source mentions over 2.8 million deaths total. And about three-quarters of those, roughly 74%, were people aged 65 or older.
And that picture has changed dramatically over time, hasn't it?
Hugely. Since 1900, and even just since 1980, there's been a massive drop in deaths from cardiovascular and cerebrovascular causes, heart attacks, strokes, big medical wins there.
But other things have risen.
Yeah, cancer as a proportion of deaths has increased slightly. And we've seen significant increases in deaths from chronic lower respiratory diseases like COPD, also diabetes, Alzheimer's disease, and suicide rates have also gone up.
What about infectious diseases?
Well, HIV/AIDS was less than 0.2% of deaths in 2019. Of course, then COVID-19 hit in 2020-21, causing hundreds of thousands of deaths, likely an undercount even then.
The source also compared the U.S. to England and Wales for 2019.
It did, and showed some interesting differences in the causes of death. For instance, heart disease was a higher percentage in the U.S., while malignant neoplasms cancers were a higher percentage in England and Wales. Also, things like influenza and pneumonia were a significantly higher percentage cause of death over there compared to the U.S. in that year.
Which highlights, I guess, the variations in health challenges and maybe healthcare systems between countries.
Definitely. And this overall shift towards people living longer but with chronic illnesses has major cost implications.
Right. The source mentioned chronic illnesses account for, what was it?
Around 84% of U.S. healthcare spending. Huge number.
Wow.
And get this. People in their last year of life, that's less than 1% of the population, remember they account for about 12% of total personal healthcare spending.
12% for
Right.
less than 1% of people.
Yeah. That was estimated at around $400 billion back in 2015. It gives you a sense of the intensity of care often delivered near the end.
Which leads us right into palliative and end-of-life care and how that whole landscape is changing.
Exactly. Because in many wealthier countries, something like 70% of deaths are now preceded by a period of illness. This makes planning for dying not just possible, but really quite reasonable and necessary.
The way we think about who needs this care has changed too, hasn't it? It used to be mostly focused on cancer.
Right, cancer was often seen as the paradigm case, maybe because its trajectory can sometimes be more predictable. But now we absolutely recognize that conditions like heart failure, COPD, liver failure, dementia, they all have later stages where palliative care is just as crucial.
So it needs a more systematic approach.
Across all specialties, yes, not just oncology. It needs to be integrated into the care for all serious, life-limiting illnesses.
And a really key point from the source. Palliative care isn't just for the actively dying, right?
Not at all. That's a huge shift in understanding. It can benefit patients with serious chronic illnesses who have symptoms and suffering, regardless of their prognosis, how long they might live. Ideally, it should be part of comprehensive care much earlier on.
And the evidence supports this.
Strong evidence, yeah. For better coordination between everyone involved, caregivers, doctors, patients, especially around advanced care planning, and for using dedicated interdisciplinary teams.
Okay. This push for earlier, integrated palliative care seems to fit with another end, where people are actually dying.
Mm-hmm. There's been a steady shift away from hospital deaths in places like the U.S. and the Netherlands. While some countries, like Belgium and Canada, still see over half of cancer patients dying in hospital, the trend elsewhere is different.
And patients prefer this.
Overwhelmingly, patients and families tend to express a preference for dying at home if possible.
The U.S. numbers show a big change.
Dramatic. Early 1980s, maybe 70% of American cancer patients died in hospital. Today, the source says it's closer to 25%.
Wow.
Yeah, the figures show a clear decline in inpatient deaths between 1999 and 2019, with a corresponding rise in deaths occurring at home or in hospice facilities.
And this is particularly noticeable for Medicare patients with conditions like cancer, COPD, dementia.
Right, especially since 2000. It parallels the big increase in hospice use overall. Back in 2000, about 20% of Medicare beneficiaries who died used hospice. By 2018, it was over 50%.
Has the type of patient using hospice changed?
Yes, significantly. While cancer used to be the vast majority, now patients with heart disease, stroke, dementia, respiratory illness make up a much larger share.
But the source also mentioned disparities.
Yes, unfortunately. Minority groups remain less likely to utilize hospice services and are often more likely to receive aggressive, burdensome treatments in the final stages of life. That's a persistent issue.
Now, there was a paradox mentioned, wasn't there? Something about hospital use.
Ah, yes. This is really interesting and gives you pause. While the percentage of people dying in an acute hospital has gone down, hospitalizations in the last 90 days of life and even ICU admissions in the last 30 days have actually increased.
Increase? That seems counterintuitive.
It does. The source cites that over 40% of U.S. cancer patients are admitted to an ICU in their last 6 months. Over a quarter are hospitalized in their last 30 days.
So, what does that suggest?
Well, it might reflect a tension, right, between people's preference for home death and the reality that managing complex symptoms or sudden crises near the end often still leads to intensive hospital care.
It really underscores the need for palliative care expertise, not just in hospice units, but everywhere. ICU, regular hospital floors.
Absolutely, which is why hospice and palliative medicine becoming a recognized medical subspecialty back in 2008 was such an important step.
Okay, so let's look at the structure of this care. What's at the core?
At the heart of both palliative care and hospice is the interdisciplinary team. Nurses, doctors, social workers, chaplains, aides, volunteers, all working together.
To address.
All aspects of suffering. Physical pain and symptoms, yes, but also psychological distress, social needs, spiritual or existential concerns, and supporting the family, too, during the illness and through bereavement.
And the timing. We touched on this, but it seems crucial.
Hugely important shift here. The emphasis now is that palliative care should ideally start months before death, focused on symptom relief, quality of life.
Regardless of whether someone is still seeking curative treatment.
Exactly. It can happen alongside curative treatment. Then, if and when the prognosis becomes more limited, often thought of as the last few months, there can be a smoother transition to hospice care, which is specifically for that final phase where comfort is the primary goal.
So it avoids that feeling of hospice being a last-minute crisis decision.
Precisely. Palliative interventions often happen well before someone meets the formal terminal criteria for hospice.
And the framework for assessing and planning care covers those 4 domains you mentioned.
Yes. Physical symptoms, psychological symptoms, social needs, and existential spiritual needs. It's about seeing the whole person, not just the disease.
How does assessment work in practice?
It's more than just a standard medical workup. It's a modified history and physical exam that really emphasizes the patient's experience, their symptoms, their suffering, how the illness impacts their quality of life day to day.
Using standardized tools helps.
Yes, using validated assessment tools and repeating them over time is critical. It helps track symptoms objectively and see if interventions are actually working. Things like symptom assessment scales, pain scales, depression screens.
Like the PHQ-9 for depression.
Right, or the PHQ-2 as a quick screen. Ensures you're looking beyond just pain.
And a really important point you mentioned earlier about tests.
Yes, especially as someone gets closer to the end. Invasive tests are best avoided unless the potential benefit clearly outweighs the burden, the discomfort, the disruption for the patient. Even parts of the physical exam that are uncomfortable and unlikely to change management can sometimes be omitted.
What about assessing social needs?
It goes beyond just asking who lives with you. The source suggests specific questions like, how has this illness been for your family? Or, do you feel close to someone you can talk to? Or, are you having trouble getting the medical care you need? It helps uncover financial burdens, caregiver strain, relationship issues, access problems.
And similarly for existential or spiritual needs.
Yeah, asking things like, how much are you able to find meaning since your illness began? Or, what's most important to you right now at this stage of your life? It opens the door to understanding what gives the patient peace or purpose without necessarily being about organized religion, unless that's important to them.
And also checking how they feel about the care itself.
Yes, asking about their perception of care. Do they feel respected? Is the information clear? Does the care plan fit with their goals? If there are concerns, you need to dig deeper.
This focus on the patient's experience flows right into communication, especially around difficult news.
Absolutely. Those emotionally charged moments. Sharing a terminal diagnosis, discussing treatment failure, shifting goals from cure to palliation, advanced care planning talks, the moment of death itself.
These conversations are critical.
Essential. And the research backs this up. Having these discussions earlier is linked to patients choosing hospice sooner, getting less aggressive, often unwanted, treatment near the end, having better quality of life.
And better outcomes for families, too.
Yes, improved family bereavement outcomes. It makes a real difference.
So how should providers approach these tough talks, the source suggests?
Preparation. Just like a surgeon prepares. Develop a structured approach and pay attention to the setting privacy is key. Sit down, connect.
Is there a specific model mentioned?
Yes, the P-Spikes procedure is detailed. It's a 7-step framework. P for prepare, know the facts, plan the setting. Centered privacy, sit down, connect. And the first P is perception, ask the patient what they already understand or suspect. I is invitation, ask how much detail they want right now. K is knowledge, share the information clearly, in small chunks, check understanding. Ease is empathy, acknowledge, and respond to their emotions. Use empathic statements. And the final S is summary and strategy, summarize, check understanding again, and make a clear plan for next steps.
Using open-ended questions and showing empathy at each stage seems vital.
Crucial. It's a roadmap, not a script, but provides structure for these difficult moments.
Building on that communication is the idea of continuous goal assessment. Why is that challenging?
Well, partly because predicting prognosis exactly is often difficult. And emotionally, it's hard for patients, families, even clinicians sometimes, to fully acknowledge the implications of a poor prognosis. There can be resistance.
So how can we navigate that?
One way the source suggests is integrating palliative care interventions or home visits earlier. This helps normalize conversations about comfort and quality of life alongside other treatments.
So it shifts the perception. It's not giving up hope.
Exactly. It's not failure or giving up. It's actively managing suffering and aligning care with what matters most to the patient now. It can make the transition to hospice, if needed later, much smoother.
And goals themselves can change over time.
Absolutely. Goals might range from cure or prolonging life to focusing purely on symptom relief, adapting to disability, finding peace or meaning, preparing for death, achieving a good death as they define it.
The source had a protocol for figuring out those goals.
Yes, another structured approach. First, ensure everyone has complete information. Then explore the patient's hopes and realistic goals. Share options that align with those goals. Respond empathetically. Make a concrete plan. Follow through. And critically, revisit and revise the plan periodically as the situation evolves.
What if someone is holding on to unrealistic goals?
That's tough. The approach isn't to shut down hope, but to gently help them refocus on what is achievable while still acknowledging their hopes. Plan for the most likely outcomes while still hoping for the best, perhaps.
This focus on goals leads very naturally into advanced care planning, or ACP.
Right. Planning for future medical care in case you lose the ability to make decisions for yourself. And the key is doing it before a crisis or the terminal phase hits.
And the need is clear from the data.
Very clear. One study mentioned found over 40% of older adults needed decisions made in their final days, but 70% of them lacked capacity, and about a third of those had no advance directives. Big gap.
Even though most people think it's a good idea.
Yeah, about 80% of Americans endorse ACP, but studies show only around 26% to 35% actually have written directives. And that percentage didn't change much between 2011 and 2016, apparently.
Who is more likely to have done it?
Older adults, People with chronic conditions, higher education, more income, white individuals, and women seem more likely to complete ACP.
So what makes ACP effective? The source outlines steps.
6 key steps. 1. Introduce the topic routinely. Frame it like insurance or estate planning. 2. Structure the discussion. Identify your proxy. Maybe use a worksheet to think through scenarios. 3. Review the plans with your proxy so they know your wishes. 4. Document it legally. 5. Update it periodically. 6. Implement it only when needed, when the patient lacks capacity.
What are the barriers? Why don't more people do it?
Clinicians feeling uncomfortable raising the topic, lacking skill or time. Patients might be hesitant too. Framing it as standard practice helps.
And the documents themselves, there are different types.
Mainly 2 types. A living will or instructional directive where you write down specific treatment wishes.
Like, I would not want a feeding tube if.
Exactly, or it could be more general values-based statements. The second, and arguably more crucial, is the healthcare proxy, or durable power of attorney for healthcare. That's where you legally appoint someone to make decisions for you.
Can you have both?
Yes, many directives combine both. If so, it's good to clarify which takes priority if there's ever a conflict between the document's instructions and what the proxy thinks is best in this specific situation.
And Pol ST, that's different.
Pol ST physician orders for life-sustaining treatment is newer. It's a medical order, usually on a brightly colored form, that reflects current wishes about specific treatments like CPR, and it follows the patient across care settings. State laws vary.
Legally, these directives are protected.
Yes. The Supreme Court affirmed a constitutional right to refuse treatment, even life-sustaining ones. Advanced directives provide that clear and convincing evidence courts look for when a patient can't speak for themselves. Generally, states should honor clear directives, even if not on their specific official form.
Okay, what about paying for these conversations? Medicare started reimbursing.
Since 2016, yes. There are specific billing codes for ACP discussions. The goal was to encourage them.
Did it work?
Well, the data mentioned suggests maybe not as much as hoped. One study found only a small percentage of eligible Medicare patients actually had a billed ACP discussion in the first year.
So reimbursement isn't the only barrier.
Seems not. Clinician comfort, skill, and lack of time likely remain significant hurdles.
All right, let's dive into managing the actual symptoms. Starting with physical symptoms, pain often gets the focus.
It does. Historically, the 5th vital sign push. But the source notes that simply focusing on pain assessment hasn't necessarily improved overall symptom management, and it happened against the backdrop of the opioid crisis, which complicated things.
So good palliative care is much broader than just pain.
Absolutely. Terminally ill patients often suffer from a whole cluster of symptoms simultaneously. Beyond pain, think fatigue, insomnia, anorexia, loss of appetite, dyspnea, shortness of breath, nausea, vomiting, and delirium is very common right at the end.
How are these assessed?
Primarily through careful listening to the patient, the history, and a physical exam, adapted for comfort. Again, the source stresses caution with burdensome tests, always weighing benefit versus burden near the end of life.
Okay, let's tackle pain first. How common is it?
Varies hugely by disease. Very high prevalence in many cancers, maybe 75% or more in advanced heart failure, common in AIDS. Lower in some others like COPD or dementia, though still present.
And understanding the type of pain matters?
Yes. Broadly, nociceptive pain from tissue damage, like aching bone pain, somatic, or deep organ pain, visceral, and neuropathic pain from nerve damage, often described as burning, shooting, electrical. Different types respond better to different treatments.
Assessment is key.
Crucial. It's subjective, so you rely on the patient's report. Use validated scales, ask systematically about location, quality, intensity, timing, what helps, what hurts, impact on function, and reassess frequently to see if treatments are working.
What about interventions?
Tailored to the patient and pain type. While multimodal approaches using different types of treatments are important, especially now, the source is clear that pain medications, particularly opioids, remain the cornerstone for moderate to severe pain at the end of life. At this stage, doubting the patient's report of pain is rarely justified.
When might other things be needed?
If pain is complex or not responding well, consulting a pain specialist makes sense. Interventions like radiation for specific bone pain or anesthetic procedures might be considered.
The WHO letter is still relevant.
It's mentioned as a framework. Start with non-opioids, like acetaminophen, NSAIDs, then add mild opioids, then move to strong opioids, often using adjuvant drugs alongside. Non-opioids can be very useful, especially combined with opioids.
And how should opioids be used for ongoing pain?
For continuous pain, they need to be given around the clock on a regular schedule, not just as needed, PRN. That prevents the pain from constantly breaking through.
What about that breakthrough pain?
For flares, you use a short-acting opioid dose, typically about 10–20% of the total daily scheduled dose. This is given in addition to the regular doses. If someone needs rescue doses frequently, it means the regular baseline dose needs to go up.
And there's no maximum dose for opioids in this setting.
That's a critical point the source makes. For pain relief in terminally ill patients, opioids don't have a ceiling effect. The right dose is whatever controls the pain, balanced against side effects. There isn't some arbitrary upper limit.
What about fears of addiction or respiratory depression?
The source is emphatic. These are extremely unlikely in terminally ill patients needing chronic opioids for pain. Those fears should not stop clinicians from escalating doses appropriately to achieve comfort.
But side effects are common and need managing?
Absolutely. Anticipate them, treat them preemptively. Constipation is almost universal with opioids. It needs active prevention, usually starting stimulant laxatives plus stool softeners right away. Failure to manage constipation is a major reason people stop taking needed pain meds.
Nausea is also common.
Yes, especially initially. Often managed with anti-nausea meds. Drowsiness, too, but that often improves within a week. Sometimes stimulants are tried for persistent drowsiness, but evidence is weak.
The source clarifies dependence versus addiction.
Yes. Dependence means you'd have withdrawal if the drug stopped abruptly. That's expected with chronic opioid use. Addiction is the compulsive use despite harm. Seeking drugs for non-medical reasons, that's rare in this population. Suspicion of addiction shouldn't be a reason to withhold pain relief.
Even with the opioid crisis context.
While risk mitigation strategies are discussed, like assessing risk, careful prescribing, the source reiterates that adequate pain relief must not be withheld from dying patients due to these concerns.
What about adjuvant analgesics?
These are other meds used alongside opioids, often especially helpful for neuropathic pain. Things like gabapentin or pregabalin are common first choices for nerve pain.
Steroids, too.
Yes, glucocorticoids like dexamethasone can be very useful for pain related to inflammation, swelling, or nerve compression. Plus, they can boost mood and appetite short-term.
Okay, let's move specifically to constipation. You said it's almost universal.
Affects 70–100% of palliative care patients, especially those on opioids. But also, other meds, inactivity contribute. Untreated, it's miserable, causes pain, nausea, vomiting, even confusion.
So prevention is key.
Absolutely. Start laxatives when you start opioids. Usually a stimulant like Senna plus a softener like Docusid. Osmotic laxatives like lactulose are also mainstays.
Nausea next, also very common.
Up to 70% in advanced cancer. Its complex can be triggered in the gut, the inner ear balance, a specific zone in the brain, CTZ, or even the higher brain, anticipatory nausea.
So the treatment depends on the likely cause.
Ideally, yes.
Right.
If you suspect slow gut motility, something like metoclopramide might help. For chemotherapy nausea, specific drugs like ondansetron are used, often preventatively. For motion sickness type nausea, antihistamines.
What about medical marijuana for nausea?
The source says it's controversial for palliative nausea at the end of life. Controlled trials haven't shown effectiveness specifically in this setting, and it can have downsides, especially for older patients. It can even cause a hyperemesis syndrome.
Okay. Dyspnea, shortness of breath. How common?
Very. Over 50%, maybe up to 75% of dying patients, especially with lung or heart conditions, often described as one of the most distressing symptoms, sometimes worse than pain.
And assessment is subjective.
Yes. How breathless the patient feels is what matters. Interestingly, the source points out this often doesn't correlate well with objective measures like oxygen saturation levels. Oximetry is rarely helpful in guiding treatment for the sensation of dyspnea at end of life.
Should you always look for reversible causes?
Early on, yes. But near the end of life, investigating causes with burdensome tests often isn't appropriate. The dyspnea is frequently just part of the disease progressing. There's also an anxiety component. Feeling breathless causes anxiety, which worsens breathlessness.
How is it managed symptomatically? Oxygen.
Surprisingly, supplemental oxygen doesn't seem effective for relieving the sensation of dyspnea in end-stage disease, according to a systematic review mentioned. It might be just an expensive placebo effect.
So what does work?
Low-dose opioids. Morphine is commonly used. They work centrally, reducing the brain's sensitivity to breathlessness. They relieve the sensation. The source specifically notes nebulized opioids haven't shown benefit.
Benzodiazepines.
Only helpful if anxiety is clearly a major component, not first line for dyspnea itself. Other simple measures help too: sitting upright, cool air, managing secretions.
All right. Fatigue and weakness sounds almost universal.
Over 90% of terminally ill patients report it, often one of the most distressing symptoms.
What causes it?
Multiple factors. The disease itself, inflammation, poor nutrition, muscle loss, anemia, infection, medication side effects, depression. It's complex and physiological.
How do you assess it?
Relies on patient report. How tired are they? How much does it limit their activity? Simple performance scales like ECOG status, from fully active to bedridden, are often used clinically and correlate with prognosis.
What can be done?
Treat reversible causes if feasible, like anemia. But a big part is education and expectation management. Help patients and families understand this is physiological, part of the dying process, not laziness. Encourage energy conservation, adjusting activity.
Taking medication.
You directly target fatigue effectively. Low-dose steroids like dexamethasone might give a temporary boost. Psychostimulants like methylphenidate are sometimes tried, but evidence is weak. Maybe modafinil? Ensuring hydration helps. Sometimes stopping other meds that worsen fatigue is possible. In the final stages, fatigue might even be protective, and treating it aggressively could be detrimental.
Okay, one more specific intervention. Palliative sedation. When is that used?
As a last resort. For severe refractory symptoms like agonizing pain or breathlessness, or maybe uncontrolled seizures, when absolutely nothing else has worked to provide relief.
Is it controversial?
Yes. There's potential for misuse if the intent is to hasten death, or if done against patient wishes, or when other options haven't truly been exhausted. Its use for purely existential or spiritual distress is particularly debated.
What's the process?
It's only considered after confirming all other interventions failed, and importantly, after allowing the patient and loved ones time to prepare, say goodbyes. Medications like high-dose opioids, or more commonly midazolam, a benzodiazepine, or sometimes propofol in a hospital setting, are used carefully to induce unconsciousness or deep sedation to relieve intractable suffering.
All right, let's shift to managing psychological symptoms now. Depression first. How common is that?
Very common. While sadness is normal, persistent, disabling sadness, hopelessness, lack of interest that suggests major depression, estimates vary, but maybe up to 25% have major depression, and up to 75% experience significant depressive symptoms.
And it impacts quality of life.
Hugely. Interferes with finding peace, saying goodbye, can worsen physical symptoms like pain.
Assessment can be tricky.
Yes, because symptoms like fatigue, poor appetite, sleep problems overlap with dying itself. So you focus more on the mood aspects. Persistent sadness, feeling helpless or hopeless, loss of interest or pleasure. Using screening tools like the PHQ-2 or PHQ-9 helps. Need to rule out medical causes too.
How is it treated?
Often undertreated. First, manage physical symptoms causing distress. Non-drug approaches like counseling help. But medication is often the core.
Which medications?
For patients with a short prognosis, weeks, stimulants like methylphenidate are often preferred because they work fast, days, and can also help with fatigue.
As opposed to standard antidepressants.
Right. Things like SSRIs, sertraline, citalopram, usually take several weeks to kick in, so they're better if the prognosis is longer, months. Mirtazapine is mentioned as promising it can help with sleep and nausea too. Careful selection based on side effect profile is key.
Okay. What about delirium? You mentioned it's common near the end.
Extremely common in the last days or hours. Maybe up to 85% of cancer patients experience terminal delirium.
What exactly is it?
It's an acute change in brain function, affecting consciousness, attention, and thinking. Key features are sudden onset, fluctuating alertness, drifting in and out, and inability to pay attention. That distinguishes it from dementia, which is gradual.
What causes it near death?
Often multiple things simultaneously. Metabolic problems, organ failure, dehydration, infection, electrolyte imbalances, brain tumors. But very commonly medication side effects, especially opioids, steroids, benzodiazepines, some anti-nausea drugs.
How is it recognized?
Look for new disorientation, confusion, agitation, sleep-wake reversal, rambling speech, sometimes hallucinations. Can be hyperactive, agitated, or hypoactive, quietly confused, lethargic. Using assessment tools like the CAM can help. Reviewing the medication list is critical.
Can it be reversed?
Sometimes if a clear cause like a medication is found early. But often near death, the underlying causes aren't easily reversible. The focus shifts to managing the symptoms of delirium.
Why is managing it so important?
It's incredibly distressing for families to witness. A difficult, agitated death is a strong predictor of complicated grief for loved ones. Also, the goal is often to provide comfort and perhaps moments of lucidity for connection and goodbyes, if possible.
So how is it managed?
First, communicate with the family. Explain what's happening, that it's common. Discontinue non-essential meds. Provide supportive care, calm environment, familiar faces, gentle reorientation. Pharmacologically, antipsychotics like haloperidol are first line for agitation or hallucinations. Olanzapine is another option, might have fewer side effects long-term, and helps nausea anxiety.
What about benzodiazepines like lorazepam?
Generally avoided alone for delirium, as they can sometimes worsen it, especially in the elderly or very ill. Might be used cautiously with an antipsychotic for severe agitation.
And insomnia.
Another very common issue. Difficulty falling asleep, staying asleep. Caused by pain, other symptoms, anxiety, depression, medications, steroids, stimulants, caffeine.
Management starts with basics.
Sleep hygiene, first regular schedule, quiet dark room, avoid stimulants. Treat underlying causes like pain or anxiety. If meds are needed, maybe a sedating antidepressant like mirtazapine or trazodone at bedtime. Short-acting benzodiazepines like lorazepams might be used cautiously, watching for confusion. Zolpidem is another option sometimes used.
Okay, shifting from physical and psychological to social needs. Financial burden comes up.
Yes, the source talks about financial toxicity. Dying can impose huge financial strain on families, causing significant distress.
Especially in the U.S.
Yes, the source notes the U.S. has less comprehensive insurance among wealthy nations. Many families report major financial hardship, depleting savings, selling assets, taking mortgages to cover healthcare costs. Lost income is also a big factor.
This impacts care.
Definitely. Financial worries are linked to poor health outcomes, higher psychological distress for caregivers, and can even influence choices about treatment or requests for aid in dying.
There was a striking finding mentioned.
Yes, a study by Mack et al. Found advanced cancer patients who had end-of-life discussions with their doctors had significantly lower healthcare costs in the final week. And importantly, those higher costs were associated with worse reported quality of death.
Wow, better communication, better quality, lower cost.
It really suggests alignment matters. Getting a social worker involved early is key to connect families with potential benefits, resources, support programs.
What about relationships?
A universal need at the end of life settling issues, saying goodbye. It's crucial for the patient and for the family's grieving process.
How can providers help?
Facilitate connections. Ensure privacy and time for families. Help navigate difficult dynamics if appropriate. Suggest ways to create memories, photos, videos, letters, memory boxes, especially important if young children are involved.
And supporting the caregivers themselves.
Absolutely critical. Families provide the vast majority of care, especially as more people die at home. They take on immense physical, emotional, medical tasks.
Mostly women.
Yes, 3/4 are women, wives, daughters, daughters-in-law typically. The burden is substantial.
And it takes a toll.
A significant toll. The source cites higher mortality rates for both current and bereaved caregivers compared to non-caregivers.
So what can be done?
Ask about caregiver needs directly. Ensure they have support, whether from other family, paid help, community groups. Refer them to support organizations. Don't just focus on the patient.
Finally, existential or spiritual needs.
Right. For many, religion or spirituality becomes more important, a source of comfort. For others, it might be less important, or the need is more about finding meaning or purpose outside of religion. Patients often wish providers were more attentive to this.
Why are providers hesitant?
Might feel it's too private, or they lack expertise. But the goal isn't necessarily to provide spiritual counsel, but to detect needs. Spiritual distress can worsen suffering.
So just asking is important.
Yes. Simple screening questions about the importance of spirituality or what gives life meaning now can open the door. It helps the patient feel heard and can identify if they benefit from talking to a chaplain or other spiritual counselor.
Okay. Let's move into managing the very last stages. How and where is this care delivered?
It depends on preferences, resources, support systems. The hospice model is prominent in the U.S.
Covered by Medicare.
Yes, the Medicare hospice benefit, Part A, requires 2 doctors to certify a prognosis of 6 months or less, generally. The patient chooses to focus on comfort care for the terminal illness, foregoing curative treatments for that specific illness.
What does hospice provide?
A comprehensive package under per diem payment, nursing, aid services, social work, chaplain, bereavement support, medications for symptom control, medical equipment related to the terminal illness.
How long do people typically use hospice?
The average stay on Medicare hospice was about 90 days in 2018, but the median stay was only 18 days.
18 days, that's short.
Very short. Half of patients are enrolled for less than 3 weeks. That makes it hard to provide the full scope of services effectively and puts financial pressure on hospices.
Which reinforces the point about starting palliative care earlier.
Exactly. Leading experts argue palliative care principles and support should be integrated much sooner, well before the last 6 months. Efforts are underway to develop non-hospice palliative care models for home, outpatient settings, nursing homes.
Can palliative care happen alongside curative treatment?
Yes, that's a key distinction from hospice.
Yeah.
Palliative care consults are increasingly available and can be billed normally even while a patient pursues treatment. The argument is this helps patients and families adjust, focus on quality of life, and makes any later transition to hospice smoother.
Now, a really tough area, withdrawing and withholding life-sustaining treatment.
Legally and ethically complex but well-established practice. Patients have a moral and legal right to refuse any medical intervention, including those that sustain life.
Even if they can't speak for themselves.
Yes. Courts recognize this right can be exercised through clear evidence of prior wishes, like an advance directive, or sometimes by a designated proxy or next of kin, although state laws vary on who decides and based on what standard if wishes aren't clearly known.
How are decisions made for incompetent patients without clear directives?
It's difficult. The source discusses frameworks, but notes limitations. The old ordinary versus extraordinary distinction is considered too vague. Substituted judgment, where proxy tries to decide as the patient would, sounds ideal, but studies show proxies often can't accurately predict patient preferences.
So what's used instead?
Often the best interest criterion. The proxy weighs the benefits and burdens of treatment options. The clinician's role is to explain those benefits and burdens clearly and dispassionately, but best interest can be subjective, depend on values, and lead to family conflict.
So in practice?
Physicians usually rely on families, objecting only if asked for treatments considered genuinely non-beneficial or harmful. Withholding or withdrawing treatments like CPR or ventilators from terminally ill patients is now standard practice in most ICUs.
Ventilator withdrawal must be particularly hard.
Very challenging. There are different approaches: terminal extubation, removing the tube, or terminal weaning, gradual reduction. Guidelines say physicians should be skilled in both and choose based on the situation and patient family preferences. Ensuring comfort with sedatives and pain meds before and during withdrawal is absolutely paramount.
How long does it take for someone to die after withdrawal?
Median time is often about an hour, but the source notes up to 10% might survive more than a day. It's unpredictable. Reassuring families that symptoms will be managed and the timing is uncertain is vital.
What about futile care? That term comes up a lot.
It does. It emerged suggesting physicians could refuse treatments they deemed futile. But the source strongly critiques this concept, emphasizing there's no objective definition of futility that everyone agrees on.
Why not?
Proposed definitions are problematic. Physiologic futility, no effect, is rare. Qualitative futility, won't end dependence on ICU, is subjective. Quantitative futility, won't work based on statistics like 1% survival chance. Involves value judgments, is a 1% chance, or 6 weeks of life, worth it. That depends entirely on the patient's goals and values, not just the statistic. Physicians' own predictions of futility often don't align with quantitative data either.
So how should these situations be handled?
Many experts now frame them as conflicts needing negotiation and communication, not simply declarations of futility. Ethics consultations are key. Some hospitals have policies for unilateral DNRs in rare cases of irresolvable conflict, and some states have specific laws providing legal processes and protection for refusing requests deemed futile after review.
Okay, moving to euthanasia and physician-assisted suicide, PAS. Definitions are important here.
Crucial. Voluntary active euthanasia. Physician intentionally administers something to cause death with patient consent. PAS physician provides the means, for example prescription, for the patient to use themselves to end life.
And terminating life support or giving high-dose pain meds
are not euthanasia or PAS. That's withdrawing burdensome treatment or treating symptoms, allowing the underlying disease to take its course. Passive euthanasia refers to withdrawing LST. This is legal everywhere.
Where are active euthanasia or PAS legal?
Legal status varies. Several European countries, Canada, Colombia, parts of Australia, New Zealand, allow euthanasia and or PAS. In the U.S., PAS is legal in several states: Oregon, Washington, California, etc. Plus D.C., usually with strict criteria like terminal illness, 6 months. No U.S. state permits euthanasia.
Why do patients request these options? Is it usually about pain?
Interestingly, no. The data, especially from Oregon, where PAS has been legal longest, suggests pain is not the primary driver for most. More often cited are concerns about losing autonomy, loss of dignity, inability to enjoy life, and being a burden on others. Depression and hopelessness are strongly associated with the requests.
Does the process always go smoothly?
Not necessarily. Data from the Netherlands and U.S. states indicates potential complications, like prolonged time to death, waking from coma, regurgitation. Those serious complications seem relatively rare based on reported data. Problems seem more common with PAS than euthanasia.
How should a physician respond to a request?
As an urgent call to explore suffering, carefully clarify the reasons behind the request using open-ended empathic questions. Avoid judgment. Reassure commitment to care. Critically, educate about alternative, robust symptom management, hospice, the option to refuse any unwanted treatment. Assess and aggressively treat underlying issues like depression, pain, or social distress. Often, after these steps, patients forego the request.
Finally, care during the very last hours. What should families expect?
Most people haven't witnessed death closely. Preparing families, especially for a home death, is vital.
What are the typical changes?
Extreme weakness, bedbound, less eating, drinking leading to dry mouth, difficulty swallowing. Secretions may pool on the back of the throat, causing a rattling sound, the death rattle. Breathing patterns change, pauses, apnea, irregular rhythms, Chant-Stokes. Circulation slows, coolness, skin mottling. Possible incontinence. Consciousness fades, often fluctuating.
These can be distressing to watch.
Very. Each change needs explanation and reassurance. Key points. Terminal fatigue is normal. Not eating, drinking at the very end doesn't cause suffering. Force-feeding AV fluids can actually worsen things, like fluid overload, prolonged dying. The death rattle isn't choking. Gentle repositioning or drying meds might help, but suctioning is usually uncomfortable and ineffective. Changes in breathing don't mean suffering if the patient is unconscious.
Addressing guilt is important too.
Yes, families may feel guilty about stopping treatments, fear they are causing the death. Reassure them that withholding withdrawing is legal, ethical, and allows a natural death from the underlying illness. They are not the cause. Repeat reassurance is often needed.
What about communication?
Hearing and touch are often thought to be the last senses present. Encourage families to talk to the patient, hold their hand. It provides comfort and channels the urge to do something.
And planning for the moment of death.
For home deaths, explain how to recognize death has occurred. Have a clear plan for who to call. Hospice, physician on call, not 911, which triggers unwanted emergency responses.
After death.
Families need time, support, comfort. Small gestures from the care team, like a bereavement card, can mean a lot. Recognizing the impact on surviving spouses is also important. So, wrapping this all up, we've really taken a deep dive, haven't we, into this intricate world of end-of-life care. Not just the medical side, but the ethical, the social, the existential dimensions, all crucial for truly comprehensive care.
Yeah, we've seen how medicine's evolving, those dramatic shifts in where people die, and this increasing understanding that palliative care shouldn't be a last resort. It needs to start much earlier.
Mm-hmm. We've unpacked specific strategies for managing those tough symptoms, pain, delirium, nausea, talked about the absolute necessity of advanced care planning, and navigated some really complex legal and ethical terrain around treatment decisions, euthanasia, PAS, drawing on the perspectives in the source material.
And here's where it gets really interesting, I think. This isn't just academic knowledge, is it? It's fundamentally about improving the quality of life, and yes, the quality of death, for patients and their families.
Exactly. Getting a handle on these details, whether it's the P-Spikes model for communication or recognizing different pain types or understanding terminal delirium, it empowers patients, families, and clinicians to navigate this incredibly difficult time with more skill and compassion.
A final thought, then, for you to consider. We know the population is aging, chronic illness is more prevalent. So how can we collectively make sure that this kind of compassionate, well-informed, accessible end-of-life care becomes the norm? How do we ensure it's a reality for everyone, no matter their background or circumstances?